a new episode of Retina Chats. I'm Mohamed, and with me, Dr. Masry.
Hello, everyone.
I'm happy today to have Dr. Mohamed Ashraf Masry joining us for this episode. Should I introduce you with the Egyptian title or the US title?
Whatever you want.
So he's a retina specialist in Joslin Diabetes Center and also a lecturer in Alexandria University in Egypt. Today we're filming this episode from Alexandria Reading Center, which is a specialized reading center for reading specifically diabetic patients and optos images. And we'll be discussing various cases of diabetic retinopathy and some controversies in the management of these cases.
Very exciting. Looking forward to it.
Okay, so the first case is a 56-year-old male patient, type 2 diabetes. He had a history of PRP, and still there is some neovascularization or a huge neovascularization on the disc, and also in the periphery, in the nasal periphery. And there's still also in the inferior nasal periphery, there's an NBE. So how would you manage this case, Dr. Mustafa?
Actually, there are a lot of skipped areas in the periphery that the PRP is not covering well. And I think this is one of the causes for this recurrence of neovascularization, whether over the disc or in the periphery. So I would start by injecting this patient to try to control what's going on over the disc, because I need a rapid control for this neovascularization. And I may defer the laser to ablate the skipped areas in the periphery 1 to 2 weeks after this injection.
So inject and then complete PRP after 2 weeks.
Yes.
And is it common to find these neovascularizers after PRP in your practice? Or if you do the PRP yourself, you don't see these cases?
If I try to put the laser marks between the arcades reaching to the OS aorta, probably I don't have these recurrences even in poorly controlled patients.
Okay.
But if we have these areas, this is a very common cause of a recurrence of neovascularization, because these ischemic areas is still a hassle in the management of diabetic retinopathy.
And do you accept? You do not accept any neovascularization, right?
Yes.
Even if it's a small one in the periphery, you will manage it the same way, right?
Because this is an active.
Okay. And what about you, Doctor?
Yeah, I think that makes a lot of sense. Although I do have to caution people, even with a full PRP, a lot of times patients do require additional treatments and additional therapy. So if we just move on to the next slide. So this is a slide from Protocol S. And in Protocol S, all patients were treated equally with a very specified protocol for PRP. So it's a very specified protocol. All sites had to do the same protocol for treatments. And it was a full PRP as described by Dr. Manhari. But despite this, 51% of patients required additional PRP.
Okay.
And most of these patients required the PRP within the first 2 years of the study. So I think, yes, doing a full PRP is essential. It is important. But even with a full PRP, you still have to monitor the patient. You still have to see the patient. And we have a saying in the US that it's not a one and done. You have to tell the patient, it's not that I did the PRP, your PDR is cured. That's not the case. 50% of the time, you will need additional PRP, and usually that's within the first 2 years.
Okay.
And I think one other thing that's important is I do believe that, yes, you should definitely try to regress all the NVEs and make sure you're not able to see them. But even in a randomized control trial, patients with PRP and patients that were being treated and monitored very closely, at the end of 5 years, still around 30% of them still had active NVEs. So per the DRCR criteria, even if you're not able to regress completely the NVEs, just maintenance of some level of stability of the NVEs is still acceptable if you're not able to regress them completely. And another point that I really have to make, and this is extremely important, This is a long-term relationship with the patient. This is not somebody that you're going to treat and then once the full PRP or once they're stable that you will not follow them up. In a randomized control trial at 5 years, despite having full treatment and being fully monitored, 4% of patients still develop neovascular glaucoma. 50% of patients had vitreous hemorrhage at some point during the study, and around 20% that had full PRP and were being followed in a big randomized controlled study ended up needing a vitrectomy. So this is a very long-term relationship. You have to tell the patients that despite everything and despite doing the best treatment possible, they may still end up with complications. They may still end up with treatment. And it's not the failure of the treatment that happened. It's not that the treatment failed. Things could have gotten a lot worse if they didn't get the treatment. But it's that the disease is very aggressive. It's continuous. And you just have to manage these problems as they happen.
I want to ask you one more question. If some doctors and some patients have this belief that, okay, and now I have PDR, I did the PRP, but my blood sugar is okay, my HbA1c is okay. Why is complications happening? So is this something that matters after reaching this stage, or
yeah? So that's
once you reach this stage, you'll have some sort of complications or some sort of possibility of having complications.
Yeah, that's a really good question. And the problem with this question is that we don't have enough data on it.
Okay.
We know that the effects of diabetes on the eye tend to be cumulative. So once you reach end stage, it's probably years and years of cumulative damage. Whether diabetes control after reaching PDR affects response to PDR, to PRP or anti-VEGF injections, that we're not 100% sure, to be honest with you. Yeah, so this slide, again, it shows you that despite having PRP, even in those getting anti-VEGF, there's a risk of retinal detachment happening. And here we're talking about mainly tractional detachment, whether macula involving or non-macula involving. So even with treatments, you can still get tractional elements and tractional detachments. And, you know, they're still high in eyes with PRP. It's about 18%. That's not very low, but it's a lot less than ranibizumab. With ranibizumab injections, just because of the way these anti-VEGF work.
Okay.
And you know, something also that's important is the development of first vitreous hemorrhage. You can see here that this is a survival plot, just showing the cumulative probability for that happening. And you know, whether you're getting just anti-VEGF injections or just PRP, you still have about a 50% chance of ending up getting a vitreous hemorrhage at some point. Okay. So don't promise your patient too much. Just tell him that it might happen, and we'll deal with the problems as they happen step by step, okay?
Let's move on to the next case. This is a 62-year-old female patient, type 2 diabetes, and for 19 years. And there's the retinopathy, it's mild retinopathy. So what about you, Dr. Mustafa? Do you order fluorescein angiography for these patients, or do you depend on the fundus images and the Optus images?
Actually, I don't depend on fluorescein for grading, as long as there's this Optus image that you can magnify probably between images, and you can get a better images and with a very good resolution.
So it's not a routine in your practice, right, to order fluorescein angiography for all retinopathy patients?
I rarely order a fluorescein in any diabetic patients.
Okay. And what about you, Dr. Masry?
Yeah, I agree. So for patients with earlier stages of retinopathy, I rarely order fluorescein, simply because one of the things that we did find out, this was a study that we did here in Egypt. We looked at a survey of ophthalmologists to see how they grade the retinopathy, and we were actually surprised that a big percentage of ophthalmologists here in Egypt, they grade the level of retinopathy, even for eyes with early retinopathy, using the fluorescein. Now, fluorescein detects a lot more microaneurysms, a lot more lesions compared to color images. So if you grade using the fluorescein, you will overgrade these patients. And so a mild case may be graded as moderate, or a moderate case may be graded as severe.
I think also the PDR study was done in the past over the colored photos. Absolutely.
All of the predictive, all of the prognostications, and all of the predictors that we have, like the percentages of progression to PDR and all that, that's all based on color.
Yeah, but I've heard some doctors mentioning that fluorescein gives you more microaneurysms and more lesions. Then these lesions are there in my patients, so why not grade with the fluorescein? It's more accurate. So what do you say about that? I know that prognostic data is from color images, not from fluorescein. So yes, these lesions are in your patients and they are in their eye, but these are not correlated with the prognostic data, right?
Yes, that's true. So, but one of the things that we recently found out from one of the more recent DRCR protocol AA papers is that, if you have, let's say you have a patient and you have their color and you have their fluorescein. If the DR severity is worse on fluorescein compared to color, they have a higher risk of progression. The thing is about the DRCR data and the papers is that we don't have specific prognostic information. Like there's no specific recommendations based on that. So while we know that it has an increased risk of increased progression, we don't have specific recommendations about follow-up based on that. So for now, I would not recommend grading on a fluorescein. I would just recommend grading on the color and just following the American Academy guidelines and the UK guidelines based on that for now.
Okay, so let's move on to the next case. So this is a 49-year-old male patient, type 2 diabetes for 15 years, and he has a severe NPDR according to the grading that we've done using the Optos images. So would you still not order fluorescein for this patient? Or would you consider ordering fluorescein for this patient?
No, I don't use fluorescein for any grading for a diabetic patient, even after doing a PRP and to check whether it is quiescent or not. So there is no need for fluorescein in diabetic patients in my practice.
Okay. So what about you, Dr. Masry?
Well, I think that that's very wise, and I think a lot of people would do that, and I fully agree with that. I think in my practice, I usually don't order fluorescein for these patients, but we did do a study at the Joslin Diabetes Center where we looked specifically at this question. So if we did fluorescein for these patients with severe NPDR, would it really add anything? And we did find that in about 25% of patients, they did have neovascularization that was not detected on color. So that does tell us that some of these eyes with severe NPDR will have very early PDR. But the PDR is very subtle, it's very early, it's subclinical neovascularization. Will that really impact treatment or not? At this point, we don't know for sure. But we do know that if you are grading on color, there is a chance that at least for eyes with severe NPDR, you might be missing some eyes with neovascularization.
And when would you do PRP for these?
This is the question. If you are going to treat a severe non-proliferative PDR, would that differ if you have this early stage of the PDR or not?
Okay.
So for me, I add a PRP for severe non-proliferative in two types of patients.
Okay.
If those patients are going to travel or they are not going to follow up in a very
if they are from a remote area,
or even if they are from the same country but they are not coming in a short period, or they are not compliant to the follow-up schedule, or if I know that those patients are not going to have a very good systemic control and definitely they will progress to a more severe form of diabetic retinopathy. So those patients that I start doing a PRP even in the...
What about one-eyed patients? One-eyed patients.
If it falls in the same two categories, I will treat it the same. But if he is a well-controlled patient and I can keep following him every 3 months, I think I'm not going to do this PRP.
Okay, what about you, Doctor?
Yeah, I agree. If we move on to the next slide, this is the slide after that. So this is actually data from the ETDRS study. This is from a subgroup analysis that happened. So we all know that the initial ETDRS study didn't show any additional benefit for PRP in eyes with severe NPDR. But there was a subgroup analysis when they separated patients with type 1 and type 2 diabetes. Actually did turn out that for patients with type 2 diabetes, PRP did significantly reduce the severe vision loss. And so I do agree with Dr. Mustafa. If I have a patient with who's I know is non-compliant, and or has very poorly controlled diabetes and has severe NPDR, I will do PRP. The other situation where I would do PRP early is if I have a pregnant patient, regardless of what stage of her pregnancy, if she has severe NPDR, I will definitely do PRP.
Does the PRP differ from the patient, the parameters or the intensity, or if the patient is severe or PDR, or it's just the same criteria for a PRP?
The guidelines are just a full PRP.
Do you add the PRP for the pregnant women because of the pregnancy will add more to the diabetic retinopathy?
Absolutely. Progression of retinopathy is extremely rapid during pregnancy. I see a lot of pregnant patients at the Joslin Diabetes Center, and they progress so quickly. And even with a full PRP, they can still progress and they can still enter problems. So the second they hit the severe NPDR stage, I do a full PRP and I monitor them.
Diabetic patients that are pregnant, not these gestational diabetes, right? Or it's the same for both?
Yeah, regardless. I mean, gestational diabetes, they wouldn't have had enough time to develop severe PDR. Okay. So we're probably talking about a patient with pre-existing diabetes, whether it's probably more type 1, but sometimes type 2. If they develop severe NPDR, I will definitely do.
And also another question, do you add this PRP in a pregnant woman to try to avoid as much as you can that those patients will receive any anti-VEGF injections?
Yeah, so anti-VEGF injections in the US, we do not do anti-VEGF injections for pregnant women just because of the possibility of the risk to the baby. So the only option we have is either doing PRP, or if the patient develops severe problems, we could go in for a vitrectomy if they have vitreous hemorrhage. So we try to go in as early as possible to do the PRP. And then we monitor the patient very closely every 6 to 8 weeks. We tell them that despite the full PRP, they still might progress.
If she has a diabetic macular edema, which is huge,
we don't.
Would you do a grid, or would you leave in peace till she gives birth?
So that's a very tricky one. That is very tricky. So probably I wouldn't do a grid because of the limited benefit for that. Steroids are safe, but if it's a young patient who's phakic, I might be very hesitant to induce a cataract or glaucoma in such a young patient. It really depends on how much it's affecting their vision and how much the patient is disturbed. A lot of times we do wait until after they give birth. But I think dealing with a pregnant diabetic patient, the care starts before she's pregnant.
Okay.
So we usually would like to see them beforehand. If they have PDR or DME beforehand, we really like to get it under control before they're pregnant. If they're pregnant and things are very out of control, it's very difficult to get it under control. So one of the things that predicts whether the patient will progress quickly during pregnancy is how high their baseline A1C was before. We all know that once they're pregnant, they try to get their A1C under control. They're under very close monitoring. But if they started out before they were pregnant, the A1C was 8, 9, 10, and then they bring it down very quickly during their pregnancy to 7 or 6, or if they haven't been followed for a very long time and they suddenly discover they have retinopathy, these are all bad signs. So if you're planning pregnancy and you have diabetes, my recommendations are start working with your ophthalmologist before you're pregnant, instead of seeing him after you're pregnant.
Okay, let's move on to the next case. So this is a 69-year-old female patient, type 2 diabetes for 23 years. And she was graded as severe NPDR, but on fluorescein, we have a new vessel. I believe this is 25% of the cases, right?
Yep.
Okay, so how would you treat anti-VEGF, PRP, or both in this case, Dr. Mustafa? It's a small MVE, right? So
it falls again in the same categories as I have said in the severe non-proliferative, because some of the early PDRs, if they are going to come for follow-up every 3 months, and I can be sure that they will follow up and they understand how big the problem is. So I would defer the laser at this point. But if they are not systemically well controlled, if she's a female and there is a possibility of being pregnant, or if they are not going to come for their follow-up, I would definitely go for a PRP.
What about you?
I think I have to agree with that. I think people forget that the recommendations for treatment actually come from, if you look at the original studies, they would treat patients that had high risk PDR.
Okay.
So less than high risk PDR, I think as time went on, we started to treat earlier and earlier. Now we're treating less than high risk. And with ultra wide field imaging, now we're seeing so much more than we did in the past. So things that would have been, that we're treating today, maybe in the past, they weren't being treated. But one point of caution I would say about anti-VEGF injections, if we move on to the next slide, this is a really important slide. If you're going to be treating your patients with anti-VEGF injections are not a cure. When they looked at the DRCR 5-year data, it turns out that even at 5 years, patients were getting on average about 3 injections. That means they could not get off of the injections. So it for some reason or the other, usually when we talk about PDR, we talk about an active stage and a burnout stage. The anti-VEGF injections, they prolong the active stage. They prevent you from getting into the burnout stage. And so I think that's really important. If you're planning on starting just anti-VEGF monotherapy, you have to be very good at communicating with the patient that this is lifelong. And we know from many studies that if patients are getting just injections and then they miss appointments or they're lost to follow-up, these patients are the ones that come back with very bad complications and loss of vision.
So I think some patients, if you are going to choose to inject an anti-VEGF to preserve the field of vision, the study by the 5th year showed that both groups have the same field effects, whether they are lasered or they receive an injection.
Yes, that was actually very surprising. They did not expect to see that, and they were very shocked when they looked at the data that there were visual field losses that happened even in the patients that just got the anti-VEGF. They were not as dramatic as the PRP, but they were very significant. And I think now in Protocol AF, which is the fenofibrate study for the DRCR, all patients are getting visual fields, and so now visual fields in patients with diabetes has become a very hot topic. And so we're waiting to see the results for that. This slide, I just want to highlight one thing that's very interesting. Only 37% of patients at year 5 did not receive any additional injections for PDR. All the remainder, about 60% or 65%, were still getting anti-VEGF. There were some patients, there was about 10% that got 7 to 9 injections at the last year.
So it's not a cure to just inject the patient once or twice. So you have to follow up them.
Exactly. If you're going to be injecting just anti-VEGF monotherapy, you have to be very clear with the patients. This is a lifelong thing. We're going to probably be doing this for 5 years or more, okay?
Okay.
And also, in the patients that were getting the anti-VEGF, only about 14% of them needed supplemental PRP. So not everybody needed. So you can pretty much control the patient very well with just the anti-VEGF, provided that they're following up. And just an interesting note, in Protocol S, the loss to follow-up rate was very high. So whether it was a short period where they were lost to follow-up or a long period, up to 50% of patients were lost to follow-up at some interval during the follow-up.
This is a very good point, favoring the PRP, because I think, as I remember, that the blood visits was in PRP like 21 visits in the 5 years and 42 visits in the anti-VEGF.
Mm-hmm.
So definitely this is a big burden and a hassle for the patient and for the services that are trying to keep the follow-ups of those patients. So
yep.
I would recommend, as we have seen from these slides, that such a case, if it is not controlled, I think PRP would be much more safer than the...
And actually, most of the retina specialists in the US agree with you. In a survey done at the ASRS, when they looked at, what were the treatment protocols, over 90% of the doctors were doing a hybrid approach with anti-VEGF plus PRP.
Okay.
Very, very small percentage of almost, single digits were doing just anti-VEGF. So it's not very common to do just anti-VEGF for these patients.
Okay, so the next case, the right eye show, it's a 37-year-old male patient, type 1 diabetes for 21 years, and there's a high-risk PDR. There's a large new vessel at the disc. On fluorescein, it's leaking, and after 1 year of PRP, there is subhyaloid hemorrhage covering almost half of the macula. So this patient received PRP and still had a hemorrhage and a vision-threatening hemorrhage. So at this stage, okay, he may need a vitrectomy or whatnot. So do you believe that if he was managed with anti-VEGF and PRP, we would have had a better outcome? Maybe he wouldn't have bled.
I don't think so, because it depends on, as I've said, that systemic control. You can inject those patients and add your PRP, and like we have seen, 50% of them over 5 years may have this vitreous hemorrhage. So it is not about the modality of the treatment, it's about a patient with a lot of comorbidities. So this is one of the complications that we all meet even after doing the PRP and even injection for a DME, and we still have some patients with this subhyaloid hemorrhage that may need vitrectomy. And as protocol has shown that it's almost 20% of those well-treated patients will have a vitrectomy.
But do you believe that combining anti-VEGF with PRP gives a better result?
No, I think this is a kind of overtreatment.
So you just PRP and maybe plus or minus anti-VEGF according to the patient.
Macular edema.
Macular
I will
edema.
inject those patients if they have a macular edema.
Okay, so what do you think, Dr. Masry?
Yeah, so I think, one of the reasons why this patient had such a, massive, this is a patient with their hyaloid is still attached, and so it's not uncommon for the blood to be trapped in that area. It's a young patient with type 1 diabetes, and so this does happen quite a bit, unfortunately. And controlling these patients is very difficult. And I think maybe there's not enough studies out there that have looked at, combined therapy. But I thought this was an interesting paper that was published in JAMA Ophthalmology. They asked the question, what sequence is better? Do we do PRP first and then anti-VEGF, or do we do anti-VEGF first and then PRP? And if we move on to the next slide, you'll see that it turns out that doing anti-VEGF first and then PRP actually did seem to be the better sequence. It reduced the risk of vitreous hemorrhage, it reduced the risk of TRDs, and it reduced the risk for needing partial vitrectomy. Now, this is not a prospective study. This was a database analysis, but I think it gives us at least some guidance as to if you have a patient that comes in with, if you're thinking about combined therapy, like what order should you be doing?
How long did they inject those patients?
So it's very variable because, again, the thing is, this is not
There's no fixed protocol for this.
So this is like how retina specialists were treating within that network. So it's really hard to say what. The good thing is that we might be having a study out of the DRCR in a few years that may be answering this question about combined therapy. So I'm going to hold out until I see some of those.
I think it's injecting the patient and observing the new vessels vanish in a few days is something that attracts more and more physicians to inject and do a PRP and combined therapy.
And the AIRRC data shows us that most ophthalmologists in the US will do a hybrid approach. And so if you are going to do a combined approach, injecting first and then doing laser does seem to be a reasonable sequence to follow.
So next case, it's also a diabetic case, 71-year-old male patient, type 2 diabetes for 29 years. And presented with vitreous hemorrhage. So in these cases, do you presume that any diabetic patient with a vitreous hemorrhage is due to diabetic complication, or do you search for other causes of?
According to the degree of retinopathy, if there is no PDR or even a severe non-proliferative, and I can see the retina well, probably it could be a hemorrhagic PVD, a tear in the periphery. So it depends on the degree of the retinopathy that may call that this one of the stages of the retinopathy, and this is a hemorrhage of a high-risk patient, or if it is another cause.
And also, I think that it's important to examine the other eye. Of course, if there's a dense vitreous hemorrhage in one eye, the other eye can give you a clue about the retinopathy, what's going on with the retinopathy in the eye with the vitreous hemorrhage. So. In this case, we can see that there is a tear that is probably the cause of the vitreous hemorrhage. So we're not all vitreous hemorrhage in a diabetic patient is due to PDR. These patients can have tears and they can have a hemorrhagic PVD, and we have to be cautious about this.
And would you do a laser retinopexy, or are you going to do a PRP in such a patient?
According to retinopathy, I will start, of course, I'll laser the break first and look for the hemorrhage to resolve, and then grade the patient and decide. So what do you think, Dr. Masry?
Yeah, I think that makes a lot of sense. I'd probably do that too. One other, I think this goes to the original point about looking for other reasons. So if you get a patient that comes to you with a very dense vitreous hemorrhage and you can't really see the retina to determine if there's a tear or not, I think it makes a lot of sense to do an ultrasound also, just to check. Don't automatically presume that this is related to PDR. And like you said, looking at the other eye may give you clues, etc. But I routinely do an ultrasound.
Okay. Let me add to this scenario one more worst point. If the hemorrhage is much more dense than this stage, and we cannot spot that there is a tear over this area, and we cannot even grade the degree of retinopathy.
I look for the retinopathy of the other eye. If he has a PDR in the other eye, then I assume this is a PDR and I can follow up the patient. Right. If the other eye is normal, I assume it's a hemorrhagic PVD and I go for a vitrectomy or surgery to address the tear that is probably there. That's how I deal with these patients. I don't know what you think.
I think that's reasonable. One thing I would not jump to doing is anti-VEGF injections.
Yeah.
I'd first figure out what's going on before injecting the patient. That's for sure.
And also history. Some patients with the hemorrhagic PVD would have history of flashes and before developing the hemorrhage. So this can give you a clue that it's most probably a hemorrhagic PVD.
Mm-hmm.
Okay, so in the next case, it's a 51-year-old male patient, type 2 diabetes, and we find that there's a small blood hemorrhage in the periphery. And the fluorescein, there is some leakage in the periphery, in the peripheral vessels, seen in the ultra-wide field images of the optos. So, how do you treat these patients? What do you think is the cause of this leakage and the blood heme?
I don't think this is an MVE. This is not a new vascularization.
Yeah. Okay.
So it's an earlier stage of a PDR, less than PDR. So I would follow up those patients, and I won't add a PRP or add any injections.
Yeah, actually, these findings are common in ultra-wide field imaging. So what do you think, Dr. Masry?
Yeah, so if you go to the next slide, if you look carefully at what it's showing some peripheral vascular leakage. This is not uncommon in eyes with something called predominantly peripheral lesions. And so this is a specific subtype of diabetic retinopathy where there are more lesions in the periphery, there's more non-perfusion, and you get this peripheral vascular leakage. And so not all of these cases are uveitic or vasculitic. You might see these peripheral vascular leakage in patients with diabetes.
So this is one of the findings that we discovered with the ultra-wide field images.
Yes.
So this is a new sign.
It is a new sign. And the DRCR did look into this. If we move on to the next slide, you'll see that they did notice that peripheral vascular leakage was present in a large percentage of eyes that had predominantly peripheral lesions. And if you move on to the next slide, you'll see that the presence of peripheral vascular leakage was actually increased in eyes with more severe diabetic retinopathy. So in the worst retinopathy, you'll see more peripheral vascular leakage. And so if you see on ultra-wide field a little bit of peripheral vascular leakage or staining, don't jump automatically to thinking that this is uveitis and you need to treat it. No, this happens in a lot of patients with predominantly peripheral lesions. And hopefully in a year or two, we might get some data from the DRCR about whether it's associated with increased risk of progression or not. So I'm looking forward to
seeing that. And we can also find these heme lesions in non-diabetic patients, right?
Yes, actually there was a great study in the American Journal of Ophthalmology looking at ultra-wide field fluoresceins in just normal patients. And they did find some of these patients did have peripheral vascular leakage. And in about 5% of the patients, you might find peripheral blot hemes. And in the periphery, even though they don't have diabetes. And we see that a lot in the reading center.
Yeah.
We see this a lot in some of our patients in the reading center.
So next case is a patient with male patient, 52 years old, type 2 diabetic, received PRP before and has a dense vitreous hemorrhage. So how would you manage this patient? Inject directly, go directly to vitrectomy, wait and see?
Actually, it looks like to be a resistant PDRs and with a flat retina, no tractions, no membranes, and I can confirm that there is no any traction element. So I would inject those patients, and most of them don't need vitrectomy, and it resolves. Some of them I may find that, and I can see that in the temporal area is again skip areas without a PRP, so I may add a top up for this PRP in the periphery to just control further recurrences of vitreous hemorrhage.
Okay. And how long do you wait until deciding to go for vitrectomy?
This hemorrhage persists like 2 months, and visual acuity didn't improve more than counting fingers to 660. I may go to vitrectomy.
What about you, Dr. Masry?
Yeah, I think I have to agree with Dr. Mohamed. I think that makes a lot of sense. And we actually know this from a randomized control trial, the protocol AB, which actually showed that. And so this trial, the way it was designed is they compared patients that were treated with aflibercept versus patients that had early vitrectomy and PRP. And it turns out that over 24 weeks, which is 6 months, at the end of it, the visual acuity was similar between both groups. And they also looked at something called area under the curve, which is the cumulative visual acuity at all measured points, and there was no difference between that as well. But if we do a little bit of a granular look, if we move on to the next slide, you'll see that at 24 weeks, there was no difference, but if we looked at 4 weeks, there was a difference between both groups. If you move to the previous slide, so there was a difference, and that does make sense, because if you're going to go in for a vitrectomy, you're going to just take out the blood very quickly. Vision's going to improve very rapidly, but with injections, it's going to take longer to clear up. So at 4 weeks, yes, the vision was better in those that have vitrectomy, but by the 6 month mark, actually the vision was very similar between both groups. And even looking at different components, comparing between eyes that had a vision of 20/32 or better, it was better at 4 weeks in the vitrectomy group. And if we looked at the eyes that had a vision of 20/200 or worse, I keep going, it was it was less in the eyes that had a vitrectomy. But if we move now to the eyes that had at 12 weeks or at 24 weeks, there was no difference between the groups.
Okay.
The vision, the mean visual acuity in
So
both groups
vitrectomy patient had an earlier recovery, but at the end, after 6 months, there was no difference between injection
and I think that's important if you're contemplating, if a patient is, for example, one-eyed or requires a very rapid visual improvement, they may want to opt for an earlier vitrectomy. But for a lot of these patients, just waiting, eventually they will reach the same point. But it really depends on how fast they want to get to.
From a patient point of view, not from a doctor point of view, if you can postpone or defer or cancel a vitrectomy, even with a later recovery of vision or whatever, how do you think the wise option?
The wiser option is to inject and wait. This is to avoid complications of vitrectomy. This should be the patient's concern. But sometimes there's, as Dr. Masry said, one-eyed patients, anxious patients, patients that are traveling, patients that don't have enough time to wait for
the problem in one-eyed patient, it's still a big surgery, and it's a vitrectomy. It is not a simple one. So I actually have the feeling that a one-eyed patient is...
they're more precious. You have to wait more.
Yes. It is not something to use and to move on. that easy.
Yeah.
So
It's something to consider, yeah, and it's a bit controversial. But these studies helped us to know that eventually they have the same visual acuity, so there's no harm in waiting. Because I've heard this before, that the blood can be toxic on the retina, or the blood subhyaloid hemorrhage can be toxic on the macula. But I believe that this study just showed us that it's okay to wait, and even if
this is the doctor point.
yeah, and if the blood stays for even 6 months, then they have a good visual acuity or similar visual acuity to the vitrectomy group.
Yeah, I agree with that. I think also one of the things that was a little interesting in this study, we always get this perception that, if you do a vitrectomy, the chance of developing cataracts is very high. One of the interesting things about this study, at 2 years, the eyes that were injected with aflibercept versus eyes that had an early vitrectomy, surprisingly, the rate of cataract extraction was similar between both groups, and it was around 30%. So I think that was a little bit of a surprise in terms of the results. But it's one other thing to think about when you're deciding your treatment.
So next case is a dense vitreous hemorrhage. So 64-year-old female patient, 26 years of diabetes. Vision is counting fingers at 1 meter, and there's a dense vitreous hemorrhage. So would you follow the same protocol, inject, wait, or if the vision is too low, then you can go for a vitrectomy from the start?
First, I will do an ultrasound to check what is going on under this dense hemorrhage. And if, again, there is no fibrotic elements in this patient, I will inject and wait. Okay. Or even I can wait without injection in those patients. And I will give her like 1 month of follow-up. If it is improving or clearing, that's very good. And I don't think that this patient had a PRP before, right?
No. It doesn't seem that she received any PRP.
So I may start to add the PRP on the obvious retina and wait for the upper retina to clear up to add the laser over this area.
And once we are in this case, I want to ask, just to make it clear for everyone, there is no oral drugs for vitreous hemorrhage, right? So you never give any oral medications for a patient suffering from vitreous hemorrhage, right?
There's no evidence-based information that says any of the oral medications work for vitreous hemorrhage, and so I don't routinely recommend them for the patient.
Yeah, no. So this is just to make clear to everyone that any drugs or oral medications given to the patient are useless for vitreous hemorrhage. So what about you in this case? If there's a too low vision of counting fingers, would you go for an injection, wait, or just go directly to a vitrectomy?
Yeah, I think that's a hard question. And the reason why it's a little hard is that when they did a subgroup analysis in protocol AB, the one group that did a lot better with vitrectomy compared to just anti-VEGF at 6 months was the group where their vision was worse than 2800, which is like less than 1/60. So in that group, there was a lot of benefit to an early vitrectomy. Now, that being said, not all patients in this group required vitrectomy. Some of them did very well. But I think it begs the question, if the patient's vision is really, really bad and the hemorrhage is very, very dense, the chances of that really dense hemorrhage clearing up is relatively low. So you may want to have that conversation with the patient earlier, as opposed to just promising him that if you wait until 6 months that it's going to clear up.
Okay.
And you can see here that the number of, if you looked at those that were worse than 2800, the ones that ended up needing a vitrectomy, they were around 40% of them ended up needing, about 62% of them ended up needing a vitrectomy. So that's really high. So that means only about 38% of them, the vitreous hemorrhage resolved without needing additional vitrectomy. And so that's quite high. And again, if you look at, what we know about the clearance rates, so the clearance rates tend to be gradual in both cases, but we would expect that somebody with a very dense hemorrhage, that the clearance of initial vitreous hemorrhage would be much, much slower in those patients. So one thing also to note is that if anyone reads this study, they might notice that the presence of vitreous hemorrhage was higher in the aflibercept group. which makes a lot of sense because you didn't really clear the blood. So whatever blood was inside the eye, you will still end up with, that yellowish organized heme at the bottom of the eye. You're more likely to have a persistence of that. So your patient may still end up with some floaters, especially if they look for them in their superior visual field. So you should warn the patient that even though their central vision has gotten better, they may still end up with some floaters.
Yeah.
And I think it's important to educate patients on that earlier on, just so they understand some of the visual symptoms that they may have. Last but not least, recurrent vitreous hemorrhage, which is a big problem. So even if their vitreous hemorrhage goes away, you should still warn the patient that just because the hemorrhage is gone, it doesn't mean that they're not going to bleed again. Whether it's in the vitrectomy group or in the aflibercept group, they are still at risk of recurrent bleeds. The bleeds may be still higher in the recurrent bleeds may still be higher in the aflibercept group, but even in the vitrectomy group, it's not a cure. It's about maybe at the end of 2 years, still around like 20% or so still ended up getting recurrent vitreous hemorrhage. So again, this goes back to our original point that these patients are very sick patients. This is a lifelong relationship with these patients. You have to counsel them very, very well to make sure that they follow up and they don't get disappointed when these complications happen. If they're expecting things to happen and you warn them beforehand, if it happens, then yes,
they can accept it more.
Exactly. And it might happen. Even in the best randomized clinical trial that patients are coming in and they're getting phone calls and they're following up, it still happens. In the real world, the chances of that happening are even higher.
So how many of your cases, even in the study of post-vitrectomy hemorrhage, especially with this kind of uncontrolled patient and a very dense hemorrhage and very poor vision, so what is the percentage of going again after 1 month of a vitrectomy to clear up a post-vitrectomy hemorrhage in your practice or even in the study?
Yeah, it happens. It's not, I don't know an exact percentage off the top of my head, but it does happen. Patients that they had a vitrectomy and they get a post-vitrectomy hemorrhage that doesn't want to clear up with anti-VEGF and they need recurrent treatments. It happens. Or patients that have had a vitrectomy and a few months later get a recurrent bleed that doesn't want to clear up and they need a recurrent.
This is one of my points in the regimen that I followed, that most of those patients with a very dense hemorrhage, all of a sudden in a unlasered patient, usually they have a post-vitrectomy hemorrhage, and you may need to go in 10 to 20% of those patients to clear up this hemorrhage. So if you can give them a chance and you can control with an injection and add a PRP, you may postpone the need for 1 or 2 vitrectomies, which will definitely those patients will need in the future.
So what you're saying that since they are high-risk patients to have multiple bleeds, then spare them the initial vitrectomy just to save them from complications of a major surgery. Okay, so the next case is 28-year-old female patient, 10 years of diabetes, and she had a pattern PRP. So what's your standard protocol for PRP? Do you use pattern laser? Do you use single shots? How many sessions? How many shots?
I usually use a pattern PRP over 2 sessions, doing the lower half first, then the upper half, because if those patients bled, so I have secured the inferior part where the hemorrhage is going to trickle down and we're going to hinder the vision, the view of the fundus. So, and I tend to go from the arcades to the AIRRC red as far as I can, and this usually needs that you ask the patient to look at different directions while you are adding your PRP. One more point that helps me a lot, that you have to make the light not coaxial, so you have to get the light tilted a little bit from your oculars, and also to get a very good focused pattern of the target light, you have also to tilt the contact lens that you are putting over the cornea slightly to the nasal side
to reach the
right eye, yes, and to the temporal side in the left eye.
Okay. What about you, Dr. Mohamed? Dr. Masry, I use pattern laser too, and I use also 2 sessions. So what do you think about this?
Yeah, so pattern laser is great. So pattern laser allows us to apply a lot of spots very quickly, and it's very efficient in clinic. But just one point of caution is that the number of spots that you apply are a lot more in pattern laser. So in pattern laser, the DRCR's recommendations are you go up to 1,800 to 2,400 spots, compared to single spot laser where it could be around 1,200 to 1,600. So if you're doing pattern, just make sure you're going to be adding a lot more spots, and make sure that the take is good so you can actually see the laser marks, because a lot of times with pattern you might have areas that don't take very well. And just make sure that you do a very complete PRP.
What is the spot size that you use? 300 or 200?
So again, that's a very good question, because it depends on your lens, because the lens changes the magnification of the spots. So the laser spot could be 200, but because of the effect of the lens, it gets magnified. Most pattern lasers, or most lasers nowadays, if you put in the type of lens that you're using, it'll automatically do the calculation for you. It'll give you the spot of the laser spot, the size of the laser spot, and the size on the retina. So usually we try to aim for about 400 microns on the retina, but for single spot it can go up to 500 microns. Between single session and multiple sessions, that's actually been looked at in the DRCR studies, and it turns out that initially people were worried that if you do a full PRP initially, that the patient will develop diabetic macular edema. That's been looked at in the DRCR. It doesn't matter. It just depends on how much your patient is able to tolerate. If you want to break it up to 1 session versus 4 sessions, it doesn't matter. The risk for DME is not the same. One thing though I do want to talk about a little bit is in Protocol S, they looked at the different factors that were associated with development of vitreous hemorrhage or neovascularization or NVI or NVG. They looked at a lot of different things. You can see here they looked at the level of NVE, NVD, vitreous hemorrhage, epiretinal membrane. Keep going. Age, race, type of PRP, visual acuity, gender, etc. But when they looked at the multivariate analysis, the only 2 things that were predictive for a composite outcome of either vitreous hemorrhage, retinal detachment, or NVI, NVG was the severity of baseline PDR. Of course, the higher risk PDR was more associated with these bad outcomes. And unfortunately, it turns out, keep going, pattern laser. So the pattern laser compared to the single spot was associated with more composite outcomes. And this is not a surprise. We've seen this. There's been many studies out there that have shown that. I'm not saying don't do pattern laser. What I'm saying is if you're going to do pattern laser, just make sure you do all the necessary spots, the 2,400 spots. Make sure you go, just like Dr. Mustafa said, from your arcades all the way up to your Ora serrata. Try to get as much laser in there as possible and try to do a good laser.
So don't go soft with the pattern laser.
Don't go soft with your pattern laser.
I would not recommend to just make the spacing less than 1 spot size, because I usually tend using the pattern with a half spot size to make them more comfortable and to be harder over the retina to just compensate the softer action of the pattern scan.
Yeah. I mean, you can see here that unfortunately the pattern laser, more problems with pattern laser. I mean, it's still very good and very effective, and for a lot of patients is very good, but just be careful. Just make sure you get in all your spots, and don't be shy with your laser. Yeah.
Okay, so can you give us a summary of?
Yeah,
you
just
wanted to give us bullet points on some of the important.
Yeah, just a quick summary. So for fluorescein, you don't need to do it for all levels of retinopathy. I mean, if you're looking for very specific things like non-perfusion or PPL, that may make sense, but do not use fluorescein for grading the level of retinopathy. It may be something you may consider in eyes with severe NPDR, because in about 25% they may have PDR that's undetected. Eyes with PDR, it's a long journey with your patient. Make sure you talk to your patient on that first visit. This is going to be a long-term relationship, okay? None of our treatments are perfect. So 50% of patients with PDR that receive PRP, unfortunately, will need additional PRP, usually within the first 2 years. And despite getting good PRP, 50% may develop vitreous hemorrhage, 4% will go on to develop NVGs, 20% will end up needing vitrectomy. So you have to prepare your patient for all of that. Anti-VEGF monotherapy is an option for patients. It has similar good visual outcomes compared to PRP. Less need for vitrectomy compared to PRP. There was a lot, 11% versus 19%. However, they can still get NVGs. They can still get vitrectomy. They may still get additional PRP in about 14% of cases or 15% of cases. And at 5 years out, most patients are still getting around 3 injections. So it's not a cure. It's another treatment that they have to be on. For vitreous hemorrhage, both intravitreous aflibercept or vitrectomy are both viable first-line options. So you may consider them. Maybe for patients with really, really dense
low vision,
you may consider early vitrectomy, maybe. And regardless of whatever treatment you choose, so 1/3 of patients that started off with a vitrectomy ended up getting additional anti-VEGF, and 1/3 of patients that started out with anti-VEGF ended up needing
the option of observing the
vitrectomy.
patient for 1 month is not there anymore.
It wasn't specifically studied in that specific study, but as you can see that, if you looked at just 1 month, that the aflibercept group compared to the vitrectomy group did better, but eventually the patients caught up by 12 weeks. I didn't show you the 12 data, but 12 weeks and 24 weeks.
Dr. Mustafa is asking the third option to just observe without injection and without
The hemorrhage
vitrectomy.
is not that dense, and the visual acuity is not less than 2800.
Well.
So I may, in a pregnant woman, that I'm
Just,
going to
yeah.
select,
It's if you're able to do PRP, if the patient's pregnant, you're able to get some PRP in. That's definitely an option. But if you've done a full PRP and there's nothing to do, you may observe that patient, unfortunately. Just observation, it hasn't been specifically studied as a third arm, so I can't give specific recommendations on that. But I think if the patient is willing to get anti-VEGF and it's safe for them, I think it's a valid option. But I can't give recommendations about just observation.
Thank you very much for watching this episode. I think it has valuable info for all ophthalmologists, and it deals with many misconceptions. And we're happy to have you with us. You're part of the team, of course. So thank you very much, and thank you, Dr. Mustafa. Thank you for watching, and stay tuned for the next episodes.
Thank you.